Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with us once again Harry Gross, who is a gentleman in charge of research at the Georgia Neurosurgical Institute, and a young man of extraordinary virtue in many ways.
Well, thank you.
Now,
sir.
having said that, it was a rather restricted compliment, I could say that. But, we work a lot on different issues, and one of the problems we work on is the healthcare system in Georgia. And the fact is we have about 11.5 million people in the state. There's about $125 billion, an extraordinary amount of money, healthcare money, you could say, sloshing around in the state. And huge amounts of attention go into this. One large law firm in Atlanta, for instance, has 250 healthcare lawyers just looking at it. So much money is there. Stakeholders watch it. There are all kinds of problems with making adjustments to improve healthcare. And we might start off, Harry, with just holding up if we can put that on, just a picture of the Macon Telegraph. I don't know if that's your favorite newspaper, but it's certainly our local one. That just says if you're having issues with that, we'll just say the Georgia Trauma Care Review points to systemic failures. And that's good, Harry, that's great. The takeaway message is that what I see in my world is that we have lots and lots of trauma patients, particularly in South Georgia, that try and get into Macon, try and get to wherever they need to go to get their injuries treated. And that the trauma system does a great job. However, it has the chances of being overwhelmed. So we might just discuss some of the systemic problems that is faced by decision makers and what can we do about them? And I think we have some slides. Let's see our first slide here. So one of the things going on is that as our Georgia population ages, more and more people live longer. The comorbidities happen and all kinds of systemic issues happen to this aged population, and that's expensive to treat. And so as we look at our healthcare system, we have to assume, without doing anything, the amount of money that goes into treatment is going to increase. And $125 billion is a lot of money for one state, but it's likely for that reason to increase. So let's see another slide here. These are some of the factors that impact. Well, so one of the things that go on are lifestyle choices, and obesity is certainly a big deal, and along with the obesity is there are bedfellows of diabetes, heart failure, locomotion issues, all kinds of things happen, and that can be a problem. Another thing driving the healthcare costs would be drug and alcohol difficulties, and there's an epidemic of drug abusers dying at an early age in the country. A lot of this was inflicted in the past by the demand for access to pain medicine, and that was particularly in evidence with the family that did this. They've been sued. The events have taken place, and there was a lot of pressure to give people pain medicine. And physicians may have tried to resist that, but that was a big problem.
That campaign was not just demand, though. The makers of opioids facilitated that demand.
Yes, they did,
demand.
and their allies, and that's right. And so some of it's quite a story. It's another story to probe. But the idea was pain was considered a fourth vital sign. And the people that many physicians propagated that, I think particularly pain doctors. So they would say, well, the doctors are not paying attention to your pain. And so you need to say what your pain level is. Is it 1 to 10? And so people would really say, my pain is a 10, and there would be a lot of pressure for the physicians to give people pretty strong pain medicine and to continue doing that. And that became a very abusive situation. And if the doctor did not give a person adequate pain medicine, the aggrieved patient could turn the doctor into the composite state medical board to examine what happened. And since the events have changed and people have understood how dangerous pain medicine can be, the opposite happens. So if people are being turned in for giving too much pain medicine, but certainly that was out there. And it was quite a story about how this enormous change in how people are treated was caused externally from well-regarded medical truth, I guess you could say that. So that's an issue. We have other things that are driving up costs. Drugs, alcohol, drunk driving, we have sexual activity, so all kinds of events are taking place, and violence. And I think we talked about what happens in the coronavirus epidemic, and it caused a substantial amount of mental illness, I believe. People are isolated from one another. That's not, people need each other. They need to be able to talk to each other and consider the world together, and being separated caused all kinds of problems. So those problems are being dealt with by expenditure in the healthcare system. So let's have another slide if we might. So one of the things going on, the way the system works, is $125 billion out there. The preponderant amount of it is being spent to actually treat symptoms, to treat diseases that appear far into far after the disease itself has appeared. So there's relatively little money being spent, $125 billion, on prevention, which would be a great thing to do, or early diagnosis. And it's what goes on in some ways is the healthcare system is kind of has a sort of a cost plus arrangement to it. So if something is wrong with your foot, and you may have injured your foot by pounding around on cement for 25 years and nothing was done about it, but then finally when your foot is in trouble, expensive intervention takes place, and the final result with the allocation of funds for health, there's a lot of inefficiencies because preventive medicine and early diagnosis are not emphasized enough.
Yeah. Nor are they incentivized by the system itself.
Well, yeah, that's
the nature
right.
of compensation within the system itself. Also,
that's right. Well, I think that's a fair point. You know, if in fact it's a capitalist country, if people said, I have a company and I'm going to be sure that I check your A1C, and if everybody I get A1C on, I get, I don't know, $1,000. So that might be something that could be done, but it has not been done. And we'll discuss this, it's extremely difficult to turn this enormous ocean liner around, but that would be a good thing to do. So let's see another slide here. Mm-hmm. Well, now this is an important issue, I think. I'm not sure how much people are aware of this. But in Georgia, we have a huge number of people that have no health insurance at all. We also have a huge number of people that depend on the largesse of the government healthcare system. So Medicare, Medicaid, and the VA are government policies, and they generally are underfund healthcare expenses. So anywhere in the state where the preponderant number of patients are not fully insured patients and have the financial resources to take care of their expenses, that particular place is going to have economic shortfall. I think that's particularly true with rural hospitals, or indeed any center city hospital that really has a large population of uninsured patients and patients that lack full insurance coverage. And I think the Atlanta Medical Center, which closed with 5,000 employees, thousands of patients, a real linchpin in healthcare in the state, closed for that reason. And if one looks at the future about what's going on, it's the economics means that any healthcare organization is going to do everything they can not to offer care to a underinsured population. That sounds kind of mean to say that, but I think that might be the case. Now, the government tries to correct that in different ways, so they're not ignoring this issue. And there are corrective measures that are out there, but still, that's the big fact. And in this, even though the resources that are necessary to maintain care in, say, Atlanta Medical, you can't get those resources. And so thus, maybe there are not enough CT scans around, or maybe there are not enough radiology techs around. The requirement is the standard of care has to be the same as the Mayo Clinic. That's basically the story there. And so that causes all kinds of difficulties, just that fact. And that's something that needs to be understood, and I don't think it's understood well enough with the healthcare system. And that's the big story. There is a two-tiered healthcare system that exists. And if you're in an area where there is a lot of insured people and you go to the facility or you're being looked after in this facility, in general, the resources that can be devoted to your care are going to be more than a place that has a lot of underinsured people. And that's a real problem in the state. And
it creates a race to the bottom, effectively, too, because as resources become a drain in predominantly poorer areas, there's a flight to wealthier areas, which then leaves those poor areas even more poor, which makes it less attractive. I mean, think about how hard it is to try and get more investment in healthcare in, say, South Georgia,
right?
Some of these places that desperately need it, but there's no market because no one would make any money.
Well, another thing you could say, I mentioned trauma earlier, is if the preponderant number of trauma patients that are coming in are underinsured or they depend on the Medicare, Medicaid story, then in fact the institution that undertakes this responsibility, it's going to be harder to make money on it, if you could phrase it that way, even if it's a nonprofit institution. And so I can't name whatever is particularly profitable, but the healthcare administrators seek out, as they use their resources, to find a medical problem that the vagaries of the government will reimburse them more. And so there's a lot of gamesmanship going on, a huge amount of gamesmanship right now in the way the healthcare system works, which are basically what the government has decided to pay for certain things, which the insurance companies go along with. Generally, not totally, but so if Medicare says, well, we're going to pay for foot amputation, I keep going back to feet, okay. Well, we're going to give you $1,000 for that, and then maybe a lot of people have their foot amputated. If they're only going to give you $10, then maybe not as many. And so that's some of what's out there, and I'm not sure the public totally understands that.
WellStar's been emblematic of that. I mean, they closed Atlanta Medical Center on its financial grounds. And to be fair, the hospital was hemorrhaging cash, though the WellStar was not itself hemorrhaging cash. They closed the hospital down. They create a huge vacancy in the trauma network. They force these patients around the rest of the state since they have to go somewhere. And they immediately moved to partner with Augusta University's healthcare system, which is much wealthier.
Well, maybe.
On that.
Maybe. But that's right. So, and I think the point along those lines is that if you're a hospital administrator or whatever, or any kind of administrator, the last thing you want to do is have an emergency room, because the way the regulations work is anybody can get care that they come to an emergency room. But if you call it, access, some other term or phrase, where you're able to exclude people from entrance into the facility by some kind of insurance barrier, then that's what the preference would be. Yeah. And so any kind of open emergency room is going to cause all kinds of issues. And That's the linchpin of healthcare. Emergency healthcare is access to emergency rooms. And so a hospital, let's say in a rural area, that has an emergency room that is many strikes against it to start with, that's very, very difficult to make their numbers, and the state tries to do something about it. But that's one of the major problems in the state, I'd say that. Well, let's see, we have another thing.
Yes.
So right now, here's the situation, I think. There are all kinds of experts that opine on the problems that bedevil the healthcare system. There are all kinds of them. And who's going to do anything about it? It's in the country, it's maybe $3 trillion. There are all kinds of lobbyists, people doing anything. And if someone said, my suggestion is this, whatever it is, then there'd be a stakeholder that would object to whatever happened, because there'd be a financial hit. So if, for instance, if money were being shifted from acute care into preventive care, you might say, well, this is going to be more bang for the buck for this. There'd be many people that would resist that. Or if anything that happens anywhere, if the government says we're going to pay for this or not pay for it, or we're going to decrease the funding for this or that, it's a big deal. So, for instance, in Medicare, the idea is maybe there's some medicine that might help with Alzheimer's disease, and if it's very expensive. So if Medicare said we're going to start to fund that particular thing, some money has got to come from somewhere else. And so all kinds of squealing, fighting going on, both mainly in Washington and to a lesser degree in Atlanta. So there's just a huge amount of struggle over how are these defects corrected or talked about. And I think the first thing to do would be to, at least in my opinion in Georgia, is to get some kind of study commission together, at least for our state, to look into some of the origin of these inefficiencies. I think that would be a big step forward if politicians wanted to do it. And I think one thing that makes people reluctant to do it, if you're a politician, would be somebody is going to be offended if you touch this. If you touch these problems, there's so much money involved. As I mentioned, one law firm in Atlanta has 250 healthcare lawyers. All kinds of struggles, fights go on, but more in Washington than here. And it's so hard to really make corrective measures. Now, the other thing that's sort of going on, there's kind of a black box with the federal policymakers on this. What makes them make their decisions, the rules they propagate, what's going on, and a rule change can literally mean hundreds of millions of dollars may go somewhere. But the real marker is what kind of health care are we getting for this extraordinary amount of expenditures? And it would be reasonable to just look at the problems. That would be my thought about it.
I would say the black box is not with the federal government, but with insurance companies. With the federal government, everything is subject to public review for rules in particular, and there is at least some level of accountability in the ability to at least elect different politicians who can regulate things and pass new laws. We have no say as an ordinary citizen in how an insurance company decides.
That's a conversation we've had, and we'll have some more about it. So what's going on for the general public is that their clinical guidelines have traditionally been propagated by physicians. So let's, I don't know, if you want, I keep talking about cutting your foot off. So the guidelines to cut your foot off, or whatever, 1, 2, 3, and if it looks blue, well, you have to cut it off. And now, when these guidelines are put out there, physicians don't make any comments about what it costs generally. But so these guidelines are there. Then insurance companies look this over and they say, we're going to have our own set of guidelines that pays attention to cost. And this is done, you could say, secretly. It's not debated back and forth. Well, we decided not to cut your foot off. If the docs say if it turns blue, but we know that costs too much money, So we're only going to let you cut your foot off if you do the following 3 things, and it's a medical emergency to do it. So these rules have been put in there to try and save money. They've been done largely secretly, and the story is that they can be appealed. So almost all insurance companies, the rules are there. They say we can appeal this if you'll just appeal it. But the problem is the process is so laborious and difficult, and the insurance companies know that. It's rare that appeals ever see the light of day.
Only about 1% of decisions are appealed, but I think of that 1%, like 95% get overturned.
It's very difficult.
It is.
And that's the other point is the delay in care that's being instituted. So these are some of the issues out there that I think some overview would be needed as much as we can do it. Of course, the world is complicated. Well, all right, now we have some malpractice stories.
Figured I'd let you squeal.
Well, we can talk about that. Well, firstly, I would say this. Malpractice or the tort system is very necessary. So we need it. And everybody needs to feel like that if the system abuses them and they're not being treated fairly, they've got the right to demand justice, if you want to say that. So that's an important part of the American psyche. No one wishes to take that privilege away, or at least I would not. The issue, however, is Georgia is number 1 in the malpractice world.
Actually, we're number 9 in payout rates.
Well, the story I got that just came out, this is very recent, within the past a month or two, and this comes of out of Washington, and this is the malpractice, dangers, and we can put numbers up. This is number 1 according to this, and maybe there's a debate about that, but certainly within the past year, there have been enormous numbers of claims that have gone through, and the system is headed for disaster. In regards to the malpractice rates are increasing, doubling, and sometimes tripling very quickly. And so we're headed for an enormous malpractice crisis. And the crisis is, in some ways, it's giving urban counties a double hit. So we could say that in urban areas, the way the demographics work, there'd be a poorer population than, say, a prosperous suburban county, and the health establishments in the poor county would not have as much money to render treatment to people, and so that's going to cause a problem. The other thing that's there, in regards to the malpractice story, is counties like Bibb or Muskogee or Fulton. In these counties, the way the system works is the people that wind up on the jury have a predisposition to, which is reasonable, to try and help the little person because their economic circumstances, the distress of the plaintiff resonates with them, and as a result, there's a particular risk to resources going into these urban counties. So it's in some ways, along with what I discussed earlier about the fact there's a 2-tiered healthcare system, which is a bad thing. The other thing that's going on is the healthcare crisis, which I think is upon us, is going to cause some resources to flow out of these areas as entities seek places that are not a problem. And indeed, I'll make this comment. The other thing going on in the state, it's not just not just healthcare providers, but truckers. And so Savannah's a huge port. There's $500 million going in there. Anybody that drives along the interstate sees thousands of truckers out there. And for Savannah to work in that huge port facility, a world-class port facility, truckers have to be able to manipulate and get around the state, and they're getting aggrieved with, it's not just physicians, it's anyone going into the situation, a very litigious society, particularly in litigious urban areas. So I think that's an issue. Well, I will move along to the lack of valuable data. So the issue right now, and maybe we could talk about this, is if anybody that's looking into the healthcare system and saying, and this would be a reasonable thing, look at what I pay for my healthcare insurance. It's an incredible number. Not only that, I've got a deductible. So if anything happened to me, I'd have to pay $1 zillion here to get anything done. And it's unsustainable. What can I do about it? What's going to happen? And every year things get worse. And so if people wanted to look into that and say, what is the deal here? They'd find that the data is very difficult to find. And I think, and we can talk about that, one reason is that, say, a hospital chain, they've got protected data. So they're not going to necessarily say what's happening. They're not forced into it. And so they're protecting their data. And the other point is, if the state wanted to study the situation, then they couldn't do it in private. You couldn't discuss this in private. So any discussions that have all the stakeholders sitting in the room, and it would be very difficult to find out what's happening. And so right now, it's very hard to get any kind of appropriate data. Would you have any comments about that, Harry?
Yeah, particularly an issue is that even for the data we do have, we don't have any aggregation of it. There's no data sets that are publicly available and easily accessible on some of this stuff. That's a huge obstacle because we can get some numbers, but there's no way to organize it and make sense out of it currently.
Yes, and so if we're an external observer in trying to say what can happen in Georgia, that's very hard to get that. So I'll make this point: $125 billion. Many people saying, I'm paying all this money for my health insurance. I'm bankrupting me. I've got to find a job where I have health insurance, and it's decreasing, and every year there's more problem. And am I going to go to the emergency room? And if I'm in the emergency room, it's just unbelievable. Or if I'm in some terrible car accident, there's nowhere to treat me. I have to go to Tennessee or whatever. I mean, there are all kinds of these encumbrances that are out there. And the corrective mechanism is lacking, in my opinion. And now, I think we're getting to the end of the slides. What are we going to do to correct that? And why don't you speak about that?
I think part of the issue is there is no plan to fix any of these things. I think that there are a number of stakeholders who have seen these same inefficiencies that we have. And some stakeholders aren't incentivized at all to address some of them. You've taught yourself about how the guild nature of physicians, places control of certain, particularly specialties, right? Within boards that have no regard necessarily for the public good, that are more about.
Not necessarily. I mean, that's probably. I mean,
for the system-wide efficiency.
That plays a role. I think that's not fair. On the other hand, it is fair to say that there is a guild mentality in the different parts of healthcare in general. That includes nurses, it includes radiology techs, it includes chiropractic people, anybody. So there are lots and lots of guilds out there that try and protect their own interests.
Yeah.
So
what I'm saying is that for the for example, we taught the neurologists, right? That said okay, we need more neurologists in the state. That is the guild nature of neurology would be counter to that interest. They would want to minimize that number as much as possible so that they're making as much as possible.
That plays, yes. And
it's a perfectly rational,
a fair
it's not good or bad. It's
fair
just the way the
statement would be,
makes.
and it's an A and a B to that particular issue. We can move on to other parts of this. But point A is what determines the number of physicians in different subspecialties, or indeed the number of people that get MDs. It's a pretty porous thing. So right now, it's possible for overseas doctors to come in fairly easily, I would say. So huge numbers are coming in from overseas. And then some specialties are, it's hard to get a position in that particular specialty. And I would say family practice, things are somewhat open in that. So there's a lot of encouragement to get primary care doctors out there, and exactly how that works, I'm not sure how you.
It takes about a decade to produce one physician in general.
Well,
So-
some of it is people come from overseas.
Well, bringing people in from overseas is the only way to fix a shortage
Well,
in the short
the
run.
other things are DO. So there are huge expansions of DO. People are out there, and the medical school enrollment have increased substantially. And how people get their niche in medicine would depend on getting residency positions, and the way the residency positions are accorded or offered is complicated, and it's not fair to say that the boards themselves are necessarily trying to overtly limit the number of people that come into their trade. However, it is fair to say what they would say is we want our desire is that we want splendidly trained neurosurgeons. And as a result, they keep adding years to the residency issue, and they only allow training arrangements, restricted training arrangements. And the actual need for a particular kind of physician is sort of haphazard, I would say. Mm-hmm. And so that's an inefficiency issue. I'd say that. The other thing that's out there is the role that different how does one render care appropriately? And so maybe there are different ways to do that, and I think we get into the technology issue. And it may be in the future that the need for physicians and healthcare providers may be diminished by using technology. So for instance, it could be possible to just put your finger in a little receiver, and that could be the data obtained from that could go to a centralized marshaling yard, and your sodium levels, your glucose levels, whatever, all that could be demarcated. And indeed, if the system went better, all kinds of cancer markers could be discovered relatively easily, and you could imagine that you're getting a feedback pretty readily. Additionally, technology is doing all kinds of things. It's attempting to do robotic surgery, for instance. There are all kinds of big advances that are taking place that presumably could diminish the cost of healthcare. And we discussed the idea of healthcare improving preventive care and early diagnosis, and I think that certainly seems to be possible in a home environment. And so those, I think technology is going to be a big thing that's needed. Now we're about end of our little epistle here, Harry. So do you have any other suggestions for how to improve healthcare?
Too many for this little
All right,
time.
okay.
But I think the best starting place, I would agree with you, is we need more data. I mean, the first step in realizing we have in solving a problem is figuring out where the problems are,
yes,
right, and what the problem is. And so to do that, we do need
and so
more
we
data.
could then, there are a number of steps that could be taken, and just getting the data is really necessary. And finally, I'll end on this. If there is, and I think this is a potential breakthrough about to happen, and that's artificial intelligence. Now there are a lot of nuances about what that really means, but to me it means getting a huge amount of macro data and getting all the variables appropriately plugged into that, and then running an algorithm that will come up with some appropriate healthcare answers. So if your sodium is 142, what does that mean exactly? And we'll come up with all kinds of solutions with the data being plugged into artificial intelligence. So I imagine if the world will hold together, the economic dislocations that we see there could well be temporary. And on that note, thank you for being here tonight.
Yes, sir.
Thank you.
Thank you for having me.
Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.